My name is Rolf-Markus Szeimies from Recklinghausen in Germany. I'm a dermatologist and running a dermato-oncology unit. And today I think it's a good day because I realized that you're all interested in the treatment of actinic keratosis. And I'd like to introduce my two co-speakers, Professor Thomas Dirschka from Wuppertal, also in Germany, and the president from the Italian Society of Dermatology, Professor Piergiacomo Calzavara-Pinton from Brescia.
We suggested a new classification scheme, which is called the Pro 1, 2, 3 classification, and this has something to do with the risk of actinic keratosis to turn into squamous cell carcinoma. And this is why very superficial treatments, like for instance curettage or cryo, do not work properly in these patients, because you only eliminate what is on top, you do not eliminate what is going downwards in the follicle. So these are the characteristics: crowding, upward directed growth, budding, papillary sprouting, acantholysis, and follicular involvement. Now, my main topic was, shall we treat actinic keratosis? Of course, we must treat actinic keratosis, but the question behind is, are there some actinic keratosis that are supercritical, which have to be treated hard, which have to be followed up closely? And maybe are there some actinic keratosis lesions that, of course, shall be treated? By the way, pain is also a criteria of invasive squamous cell carcinoma of the skin. But this is not by scratching, this is by pressure. So if you press on bigger lesions and patients indicate that this is very painful, this lesion is suspicious of squamous cell carcinoma. So pain seems to be a relevant point of view. So you can find all different types of mutations and markers that have been described. It is not a typical and single event that happens. It's a field event, different events that interact, and for that we have to analyze epidermal and mesenchymal mutations in correlation with different AK types and find prognostic markers indicating risk of cancerous transformation. Thank you very much for your kind attention.
Another aspect we have to consider is that the numbers, of our therapies which are registered are only registered for the small fields, because we have only the 25 square centimeters area, whereas, for example, with photodynamic therapy, it's possible to treat the large areas. So this is one of my patients in Recklinghausen. He's a petrochemical engineer working in the Arab countries for many years. However, we performed daylight PDT and I didn't give him some money for a light smile here. He didn't feel any pain overall, and the downtime was roughly 1 week, and then, as you can see here, a fantastic healing and also a cosmetical outcome in this patient afterwards. The convenience with the instructions to perform this therapy at home were also very satisfying for the patients, and the same was the procedure itself, so the administration of a sunscreen to scratch the keratotic lesions and then apply the methyl ester. So this was very convenient for the patients to be done at home. One session is as effective as ingenol mebutat, with lower local adverse reactions, better cosmetic outcome, higher patient preferences, and we are also possible to treat large areas in a single session if this is convenient. Mild daylight PDT is also more effective than diclofenac sodium, studied with an indirect comparison trial, and it is a preferred field treatment for patients even when they perform it in a self-administrative manner. So daylight PDT is rated as preferred option for patients with multiple actinic keratosis on both small and large fields. And I'd like to thank you for your attention. These are my patients who really love this therapy. Thank you.
If you are old, very old, with some spot of Alzheimer in your brain, it's difficult that you apply regularly the cream on your face for several days. And you see here that, for example, if you have a small area, maybe that PDT is not the right choice, but if you have an area that is half face, half scalp or forehead, The cheapest way is mal-PDT. And you see here that the most expensive way, at least in Italy, look at here, that is more than 2,000 euros are inguinal mebutate and diclofenac sodium. Why? It's less expensive here, but you need a lot of packages to fulfill the treatment, to complete the treatment. But when you are in front of a patient, okay, you must have in mind that some patients may accept a strong reaction for 1 or 2 days more than a mild reaction for 90 days, or the opposite. And at the end, at the very end, I believe that there is not a treatment that is always the best, but you must tailor the treatment on the single patient. Obviously, with daylight PDT, you have the treatment that is the most effective, the most tolerated, that has the lowest degree of inflammation, and also the cheaper. But okay, it can be the best patient for most patients, the best treatment for most patients. Thank you.